radiological and the pathological aspects pertaining to recent advances in neck management. So, whenever we talk about the ideology of surgical management of the neck, the question that comes to mind is to dissect or not to dissect the neck. Now, as we all know, cervical nodal metastasis is the single most important prognostic factor in oral cancers, bringing down the survival by 50%. In an N+ neck, there is really little to think about. We have to do the neck dissection. Whether unilateral or bilateral really depends on the site involved, whether it is crossing midline, the stage of the disease, whether the ipsilateral neck has metastatic nodes or not. The second question, that is the extent of dissection, is something that is probably more contentious. Few would propagate comprehensive neck dissection for this, whereas others would say that selective neck dissection 1 to 4 would also do the job. N0 neck is where the major controversy lies. We have been trying to answer this question of observation versus elective neck dissection for the past maybe 3-4 decades. We still haven't found the answer, especially with the gaining popularity of sentinel node biopsy. We're still at crossroads as of now. So the proponents of the elective neck dissection group, they cite decreased relapse rates, better survival in the elective neck dissection, better prognostication of the neck, and also lesser radicality of neck dissections. Now, we hardly ever do radical neck dissections. Thus bringing the morbidity of neck dissection down. So these are the points that the proponents of elective neck dissection group point towards. Whereas the other group, that is the pro-observation group, they say that maybe we are still over-treating unnecessarily 70% of the cases in which the neck actually comes negative after a neck dissection. Add to that the morbidity of neck dissection, the increased cost. They all point towards maybe that observation is good enough. And lastly, we have a very reasonable and cheap and readily available tool in the form of ultrasound to perform surveillance of the neck, not just pre-operatively, but also in cases relapses occur later, and hence we can pick up the nodes later. So really, it's one way or the other. So to answer this question, many randomized control trials were done in the 80s, in the 90s, and the early 2000s, but unfortunately, none of them were methodically very strong. They all had small numbers, and they conclusively did not point towards one modality over the other. Till the time this landmark trial came up by Dr. De Cruz, in NEJM, and this was the largest randomized control trial till date answering this question, and it conclusively said that elective neck dissection saves lives. There was an improvement in overall survival by 12.5% and improvement in DFS by 23.6% in this trial. Shortly thereafter, the same study came by the UK group, by Hutchison et al. It echoed the findings of N0 trial with significant improvement in survival. In addition to the RCT, they also included patients in the so-called real-world cohort so that the applicability of the trial is checked in the general population outside of a trial setting. In addition to this, they also conducted a meta-analysis of all the RCTs conducted till date, and they concluded that within a generalizable real-world setting, early oral cancer patients who undergo upfront elective neck dissection have a lower risk of death or recurrence than those who are observed. So together, the N0 and the SEND study leave little room for discussion. They definitively propagate elective neck dissection over a wait-and-watch approach. There was significant improvement in overall survival and local relapses. The N0 trial also told us that pattern of recurrences in the observation arm were more ominous, with more incidences of N3 nodes, thus warranting an MND or an RND for salvage, which in turn affected the quality of life. The salvage rates of the patients who were observed and recurred later was also a dismal 17.5% only. The same study also told us that the benefit of elective neck dissection is there even in T1 very superficial tumors as well. But there is another side of the story to it as well. The critiques of this trial mentioned that there were a few problems with these trials as well. Ultrasound was used to evaluate the neck, which one may argue that is a subjective tool and there is inter-observer variability. Secondly, there was unequal adjuvant treatment that was given in the two arms in the N0 study. A larger proportion of patients in the elective neck dissection arm, because they were pathologically staged better, had more received radiation. A more number of patients received radiation in that arm, probably leading to treatment intensification and influencing survival. Another point was that even after elective neck dissection, a quarter of the patients still recurred in the neck, 30% of which were in the neck alone. So probably the false negative rate of a blanket elective neck dissection is also not zero. So this raised the question, rather the question of over-treatment of 70% of the cases who do not have nodal disease. This question was still lurking around amongst the head and neck community. Then came sentinel node biopsy, which is not really a recent advancement. It has been around since the 1960s. It was popular in melanoma and breast. Recently gained popularity in head and neck as well. In a nutshell, this procedure is an intermediate tool between the routine diagnostic methods that we have and a formal neck dissection in evaluation of early oral cancer. And it gives us an attractive tool to maybe find out occult nodal metastasis better. This was the trial by Claire Schilling, the SENT trial, which really set the ball rolling for sentinel node biopsies. It was a multi-center trial across 14 centers, 415 patients. Sentinel node was detected in 23% of the patients. Negative predictive value was an impressive 95%. There were only minor complications. The procedure was deemed to be pretty safe. However, the false negative rate was 15%, which was probably too high, and the head neck community was probably not convinced with the sentinel node as yet. More so when it was reported that less than half of the patients who recurred in the false negative group could actually be salvaged. Having said that, there were multiple other meta-analyses that have come up recently looking at the diagnostic efficacy and the diagnostic safety of sentinel node biopsies. They report a pooled sensitivity of 85 to 87%, negative predictive value of 94%, and pooled identification rate of 98%. All very impressive figures. Combination of CT and MRI along with sentinel node biopsy was probably the most accurate tool to assess the N0 neck according to one of these meta-analyses. So in all, in a nutshell, they conclude that sentinel node biopsy is a good tool to detect the most likely basis of occult nodal metastasis and has a reasonable diagnostic accuracy. In addition to this, another advantage that the sentinel node biopsy provides us is identification of aberrant lymphatic pathways. In the SENT trial alone, aberrant contralateral or bilateral drainage was from well-lateralized lesions was seen in 12% of the study population, which would have definitely been missed had it not been for sentinel node biopsies. Another recent study by Den 2 et al. Mentioned 16% contralateral neck metastasis. Another interesting finding in their study is that the level 4 and level 5 stations were the first echelon nodes in recurrent cases, thus raising the point of completion neck dissection in cases who have already undergone a suprahumeral neck dissection before and have recurred. So we had evidence that diagnostic modality, sentinel node as a diagnostic modality is good. What was lacking was head-to-head comparisons with elective neck dissections. And this is what changed in 2020. We had two trials, one of them by, the first one by Garel et al., the French group, which had 279 patients. They included T1, T2 oral as well as oropharyngeal cancers. The standard neck dissection arm was compared with SNB navigated neck dissection arm. Their primary endpoint was neck recurrence-free survival at 2 years. They also looked at disease-specific survival, overall survival, shoulder function, and hospital stay length also as secondary endpoints. And they reported that the neck nodal recurrence-free survival was equivalent in the two arms, but the sentinel node biopsy arm had better function, better shoulder function. Similarly, not long after the first trial, the second randomized control trial by the Japanese group came up. It included T1, T2, N0 oral cavity patients only. They also excluded T1 tumors with the depth of invasion less than 4 millimeters. It had a similar trial design, except that it was a non-inferiority trial. The primary endpoint was 3 years overall survival and not local recurrence-free survival. They also looked at neck functionality and disease-free survival as well. And they also concluded similar results, that survival outcomes were non-inferior in the sentinel node group, but with better functionality scores. So we have 2 trials which are conclusively saying that sentinel node biopsy is as good, but are they really practice changing? We need to dissect the methodology of these trials, and there were quite a few methodical flaws which needs to be taken into account before they're made practice changing. Both the trials had a non-inferiority margin of 12% and 10%, which is pretty high, and this remains the most important point of criticism of these trials. The French trial included oropharyngeal cancers as well. We now know that oropharynx behaves differently, especially the HPV group. Another point of contention was that the adjuvant treatment was not consistent between the two studies. Probably the indications of adjuvant treatment were also debatable. Then there was the question of isolated tumor cells and micrometastasis. I'll be talking about that shortly. Both the trials mentioned that the functional scores were better in the sentinel node biopsy group. However, the analysis was done by comparing the sentinel node biopsy only group versus the elective neck dissection patients. A better analysis would have been comparing the patients who had sentinel node biopsy along with completion neck dissection, and then comparing that with elective neck dissection. What about micrometastasis and ITC? Are they really relevant? The short answer is we don't know. The prognostic significance of these are still debatable. And this is highlighted by the fact that the 3 main sentinel node trials that we have till now also do not have a consensus on the outcome of, or the prognostic significance of ITC. The Schilling trial and the Hasegawa trial, the Japanese trial, they considered ITC as PM plus and went on to do a completion neck dissection. However, the Garrel trial did not do so. In fact, in the Garrel trial, the 11 patients which did have ITC and did not undergo neck dissection did not have neck nodal recurrence at all. So this again raises the question that maybe SNB positive necks, because they are increasingly detecting ITCs and micrometastasis, they are receiving unnecessary intensification of treatment. So this is another point of contention that we still have till date. So where do we stand finally? The level of evidence definitely seems to be in favor of END as of now, in view of big studies unequivocally concluding better survival rates. However, the sentinel node biopsy has gained a lot of popularity owing to the 2 recent RCTs, which both suggested that the survival outcomes are similar with better functional outcomes. Both the trials have their own drawbacks, which need to be taken into account. In addition, when we look at the cost, the logistical issues, and the technical ambiguities associated with sentinel node biopsies, there are still significant challenges to its widespread use. Now, coming on to minimal access neck dissections, they're, so to say, a lot in fashion over the past few years. They gained enthusiasm, particularly in Asia, more specifically in Korea, where cultural aspects motivated patients to avoid a neck scar as far as possible. The earliest studies of minimally accessed neck dissections via the retroauricular and the transaxillary route was published by Professor Koh's group in 2010s, wherein they showed the feasibility of these approaches. Just to enumerate the approaches that we have for minimally accessed neck dissections: the retroauricular approach via a facelift incision. Then we have the transaxillary approach, which can either be a gasless approach, wherein we apply the Chung's retractor, or we can have insufflation techniques as well, wherein we use standard laparoscopic instruments and insufflate the neck and then perform the neck dissection. Then there can be a combined retroauricular and transaxillary routes as well. And finally, transoral route for neck dissection has also been described, although this is more popular for thyroidectomies. This was again a recent meta-analysis comparing the two modalities. It came out in 2018 in Laryngoscope. So look at the diamond of the forest plots of these parameters. Barring the operative time, which clearly favored the conventional neck dissection, and the cosmesis, which clearly favored the robotic neck dissection. Other parameters like recurrence, nodal yield, and hospital days were not significantly different between the two arms, as we can see by the diamond lying on both sides of unity. This was another meta-analysis that came out just last year from our country. They also concluded more or less similar results, wherein the minimally access neck dissection patients had significantly better cosmetic outcomes, along with lesser hospital stays. Recurrence rates were equivalent. Other parameters like drain duration, nodal yield, and complications were also similar in the two groups, but it was favoring minimally access neck dissections. But the minimally access neck dissections had significantly longer operative times in this meta-analysis as well. So to sum up, these techniques appear to be equivalent to conventional open approaches with regards to early oncological efficacy. We do not have data about long-term data on these techniques as yet. The long-term functional outcomes also appear to be similar, and superior cosmetic outcomes in the minimally invasive techniques. However, they have significantly longer operative times, cost. We do not have randomized data to pick one over the other. Even the studies which have mentioned superior cosmetic outcomes do not use validated tools and questionnaires to report such outcomes. And it is very likely that these studies had an inherent bias as well. Moving on from the ideology towards the radiological aspects of recent advances in neck dissection, and really the Naira scoring system is something that has stood out in recent years. It was published first by the American College of Radiology in their original white paper in 2016. So akin to the BIRADS and the TIRADS, we now have the NIRADS in the neck as well, which aims to provide a standardized risk stratification system to guide the management of patients which have been treated for head and neck cancer. So this is specifically for post-treatment evaluation of neck. This also aims to improve communication between the radiologists and the clinicians by suggesting concrete actionable steps in each report that the radiologist gives out. So this is the NIRAD's scoring system. It has categories, it ranges from categories 0 to 4, with index of suspicion of recurrence increasing as the category increases. Now, what it does is that it places the imaging findings based on a predefined lexicon into specific categories, and then specific management steps are suggested by the radiologist in his or her report that the radiologist feels should be done according to what he sees on the scans. To give you an example, so NIRAD 0 is basically an incomplete study. When a new baseline study comes to the radiologist, wherein no prior imaging is available to him, it is difficult for him to conclusively say whether it is a recurrence or a post-treatment change. So this category would be assigned an NIRAD 0 category. It's rarely used now. It should be, ideally, a new score should be attributed once the previous scans are available. To give you an example, this is a scan of a post-treatment CA oropharynx treated with CTRT 1 year post-treatment. And the radiologist sees a neck node with no ominous characters. It is not too large in size, but he does not have anything to compare it with. So this would be assigned a category of NIRAD 0. Going to the same scans, once the radiologist has a PET scan with him or the previous baseline scans available to him, the radiologist sees that it is not an abnormal node. There is no residual nodal tissue uptake at all in this node, or the size has not increased compared to the previous scan. The radiologist can safely put it as NIRADS 1, which means no evidence of recurrence, and the action suggested in such a category is routine surveillance. NIRADS 2 is low suspicion nodes, wherein there is residual nodal tissue with minimal FDG uptake, or a growing lymph node without morphologically abnormal features like necrosis or ENE. The positivity rate of NIRADS 2 is 17%, and the action suggested is short interval follow-up. NIRADS 3 is high suspicion. It denotes to a new or enlarging lymph node with intense FDG avid or abnormal features like necrosis. It has a 59% positivity rate, and the action suggested is biopsy or an FNA at the least. NIRADS 4 are definitively known recurrences. They are pathologically proven. They are more or less used once the patient is on chemotherapy and the radiologist wants to assess the response to chemo by comparing it with the pre-chemo scans. So the action suggested in this category is clinical management based on what the radiologist sees and how the tumor has responded to treatment. Following the original white paper, there were multiple flurry of studies looking at the performance of NIRADs and the reproducibility of NIRADs. And almost all of these studies jointly report that there was good inter-reader reproducibility of this NIRAD scoring system in both the primary as well as neck assessments. They were also reported a high positive predictive value of NIRADs 3 and a good negative predictive value of NIRADs 1 and NIRADs 2. So this scoring system really looks like something which is promising and could be used in a more widespread manner in the times to come. Finally, no talk on recent advances can really be complete till we talk about translational studies. Molecular markers predicting nodal metastasis is an area of research that has been going on since the past decade, probably even more than that. As we all know, tumor progression and metastasis is a multi-step process involving multiple genes and multiple genetic pathways. Few genetic targets that have been studied till now to have a potential role include ecadherins, integrins, MET oncogene, EGFR, etc. They are all involved in one or the other aspect of tumor progression, right from tumor proliferation to angiogenesis to evasion of senescence, etc. This was a very recent study published in Frontiers in Oncology, wherein they looked at 112 tumor samples and they looked at the genetic expression profiling of these tumors. And they came to the conclusion that CDKN2A gene and PLAU gene, standing for urokinase type plasminogen activator, were two genes that were significantly associated with lymph nodal metastasis. Using logistic regression analysis, a prediction model was developed by the authors based on these two genes, along with T stage and as well as the grade of the tumor. And they found that the area under the curve was 0.8, sensitivity of close to 70% and specificity of 80%. Pretty impressive. However, there have been similar studies in the past as well. Many of these markers have been shown to be associated with metastasis, but the problem is that they're all small-scale individual studies with different methods of detection. None are of use in clinical practice as yet. While a significant challenge that is involving the translational research right now is, while these markers may be contributing to metastasis jointly, attributing one of them conclusively to metastasis is proving to be difficult, because we know that metastasis happens because of multiple genetic pathways and multiple genes are involved. So what is needed is large-scale genetic studies enabling comparison of large number of genes between patients with metastasis and those without. And this probably may give us more insight into this issue, and this could be a potential game changer in the times to come. So that was my take on recent advances in neck management. I thank you for your patient listening.
Thank you, Shikhar. Very nice and informative talk, especially highlighting the points on NIRADs, which is actually a very recently developed and used lexicon to standardize the reporting between users in different institutes and the same institute. Plus, it also helps us in deciding the degree, the presence or absence of recurrence with a certain degree of certainty. So this is definitely which is coming in a very big way, and we should be using it at every onco center now. Now coming on to case discussion part, the case will be presented by Dr. Kinshuk Chatterjee, his third year MPH resident from Tata Memorial Hospital, Mumbai. I would like to invite all our esteemed faculties for the case discussion. Dr. Deepak Balasubramaniam sir, Associate Professor, Head and Neck Surgery, Amrita Hospital. Sir, are you there? Deepak sir?
I'm here, Ravi.
Dr. Sagar Vaishnapan, he could not come today because of some emergency case. Dr. Narayan Subramaniam, he is consultant and HOD, Head and Neck Oncology, Shankar Cancer Hospital, Bangalore. Dr. Narayan.
Thank you.
Dr. Kranti Kumar Gangeti, Consultant Head and Neck Surgery, Baswat Karathram Cancer Hospital, Hyderabad. Dr. Kranti.
Yeah, Ravi, I'm there.
Hi.
Thank you.
And Dr. Shikhar Sani, again Assistant Professor, HPCH and Tata Memorial Centre, Mullanpur, Punjab. Dr. Shikhar, please.
Yeah, I'm there, Ravi.
Okay, please start with the case discussion.
Yes, sir. So starting off with the case presentation. So my patient is a 46-year-old male patient, a resident of Perel, Mumbai. He works in a printing press. He presented to the OPD with the chief complaints of an ulcer over the tongue on the right side for last 3 months and pain over the ulcer for last 2 months and a foul smell emanating from the mouth for the last 2 months.
So your slide.
Hello. Coming on to the history of present illness, the patient was asymptomatic 3 months back when he noticed a small ulceration over the right side of the tongue, which was initially of the size of a peanut and gradually progressed in size to attain the present size. It is associated with pain over the ulcer, which is radiating to the right ear, which gets aggravated on chewing and gets relieved with painkillers. There is also history of excessive salivation present since last 2 months, and for the and there's also history of foul smell.
Sorry, can you be a bit louder, please? I really can't hear you.
Sorry, sir.
And your slide isn't changing. You're not on full screen. You're still on the first slide.
Excuse me. Sorry, sir. So this is my first slide, sir.
Yeah, full screen, please.
Yes, sir. Is it showing full screen, sir, right now?
Not yet.
Okay, sir. I have. I'll just stop sharing and then reshare, sir. Just a second. Is it full screen now, sir?
Still not. I think it's okay. Go ahead. Still on screen, but I think it's okay. Go ahead.
Now, has the slide changed to the second slide, sir?
Slide 2.
Sir, am I audible, sir, right now?
Yeah, we can hear you.
So my patient is a 46-year-old male patient, resident of Parel, Mumbai. He works in a printing press. He presented to the OPD with the chief complaints of an ulcer over the tongue on the right side for last 3 months, pain over the ulcer for last 2 months, and foul smell emanating from the mouth for the last 2 months. The patient was asymptomatic 3 months back when he noticed a small ulceration over the right side of the tongue, which was initially of the size of a peanut, gradually progressing in size to attain the present size, associated with pain over the ulcer radiating to the right ear, which gets aggravated on chewing and gets relieved with painkillers. There's also history of excessive salivation present since last 2 months and foul smell emanating from the lesion. There is associated history of inability to protrude the tongue and slurring of speech, which has developed over the course of illness. There is difficulty in chewing. The pain gets aggravated. There is no other ulcer elsewhere in the oral cavity. There is no history of loosening of any teeth, and there is no history of any swelling in the neck. The patient gives history of tobacco consumption in the form of chewable tobacco, approximately 2 to 3 pouches per day for approximately 25 years, and has recently quit the habit of taking tobacco. And there's occasional history of alcohol intake, which, according to the patient's history, could not be quantifiable. There is no history of cough or hemoptysis. There is no history of any bone pain. There is no history of any significant weight loss. The patient has not sought any treatment elsewhere for the present cause. There is no family history of malignancy. There is history of dental capping done approximately 10 years back. There is no history of diabetes, blood pressure, COPD, asthma, or any cardiac or renal illness. Shall I move on to general examination, sir?
Could you summarize the positive findings in your history?
Yes, sir.
And what they mean?
Yes, sir. So my patient is a 46-year-old male patient with a history of tobacco chewing for approximately 25 years, has recently reformed, presented with the complaints of an ulcer, which is gradually progressive over the right side of the tongue for the last 3 months. And there is foul smell emanating from the ulcer and associated pain over the ulcer radiating often to the right ear.
Okay, so what do you infer from each of them? So what do you infer from the foul smell, the pain emanating to the right ear, the reduced movement in the tongue, hypersalivation?
Yes, sir. So hypersalivation is because of the constant irritation by the ulcer and the inability of the patient to swallow his own saliva. That is because of the restriction in the tongue movement. The restriction of the tongue movement can be explained by the fact that the lesion is an infiltrative one and has possibly infiltrated the extrinsic muscles of the tongue. And the foul smell is also because of pooling of saliva in the oral cavity because of inability by the patient to swallow his own saliva, and also some superadded bacterial infection.
And the pain emanating to the ear, what do you think?
So, sir, this is a referred otalgia. So, for lesions in the anterior tongue, the general sensation of the anterior tongue is via the lingual nerve, and the spatial sense is by the chorda tympani. So, for lesions which are infiltrative in nature and located in the anterior tongue, this the referred otalgia to the ear is carried via the lingual nerve, which forms the afferent limb, and the efferent is by the auriculotemporal branch of the cranial nerve 5. So this pain will be felt in front of the ear on the anterior aspect of the tympanic membrane and the external auditory canal.
Good. Any other questions, or should we go ahead?
Yeah, go ahead, Kinshuk.
Yes. So coming on to general examination, the patient is conscious, alert, cooperative, and well oriented to time, place, and person. He is of average build. ECOG status is 0. The vitals recorded are within normal limits. There is no pallor, icterus, cyanosis, clubbing, or edema, and there is no generalized lymphadenopathy. Coming on to the local examination of the oral cavity in the neck. His mouth opening is adequate. On inspection, the mouth opening is adequate. The approximate inter-incisor distance is around 3.5 centimeter. Oral hygiene is poor. The mandible is dented. There are no whitish bands noted over the buccal mucosa on either side. And an approximately 4 into 2.5 centimeter ulcerative lesion is noted over the right lateral border of tongue. The mucosa over the RMT looks free. Bilateral tonsils also look free. Coming on to palpation, the purpose of palpation was to confirm my inspectory findings and to get some additional points on it. There's an ulcerated growth approximately 4 into 2.5 centimeter involving the right lateral border of the tongue with the following extents. Anteriorly, it's 1 centimeter behind the tip of the tongue. Posteriorly, 1 centimeter behind the circumvallate papillae. The left base tongue is supple. Medially, the surrounding induration reaches till midline. Laterally, the floor of the mouth is free anteriorly, but the lesion abuts the floor posteriorly with less than 0.5 centimeter of supple mucosa between the lateral edge of the growth and the mandible. The RMT is free. The tonsillolingual sulcus is indurated, but bilateral tonsils are free. Coming on to examination of neck, there is no visible swelling in the neck. There is no visible scar, sinus, or fistula seen over the neck on either side. On palpation, there is no cervical lymphadenopathy. And the thyroid on palpation is, there's no nodule palpated in the thyroid. On systemic examination, the chest is clear. Normal vesicular breath sounds are auscultated. Bilateral air entry is equal. There's no added sounds. And the CVS and the CNS examinations are within normal limit. To summarize my case, a 46-year-old gentleman with history of tobacco consumption for last 25 years presented with an ulcer over the right lateral border of tongue with referred otalgia and halitosis without any neck swelling or symptoms suggestive of distant metastasis. On examination, an approximately 4 into 2.5 centimeter ulcerated growth is noted over the right lateral border involving the right base tongue and abuts the lateral floor of the mouth with restricted tongue mobility and no cervical lymphadenopathy.
Did you
do a Hopkins examination?
Yes, I have done a Hopkins examination. I missed to write it. So there was no lesion seen in the epiglottis, the larynx, and the hypopharynx, and bilateral vocal cords were mobile.
And when you palpated the base tongue, how far was it extending? Was it just at the circumvallate papillae, or?
So it was extending approximately 1 centimeter behind the circumvallate papillae on the right side. The left base of the tongue was free. The vallecula I couldn't palpate properly. So the posterior limit of the growth was not palpable during the office examination.
So we are not sure about the posterior extent completely, clinically.
Not sure clinically, sir.
And then what about the tonsillolingual sulcus and the anterior pillar?
So the tonsillolingual sulcus was indurated. The anterior pillar was free. The tonsil was free, sir. Was supple.
Oh. Okay, good. Yeah.
Did you cover tongue movements on examination?
Yes, sir. Restricted tongue mobility, sir.
Okay. In which direction? Did you cover all the tongue movements? How do you examine tongue movement?
So I'll ask the patient to protrude the tongue first. And if he can protrude the, and we'll see whether he can protrude the tongue fully or not. And I'll also ask the patient to move the tongue sideways inside the oral cavity.
Okay, so what muscles are you checking for and what does it mean if you have a restriction in movement?
So basically by asking the patient to move his, protrude his tongue out, I'll check the extrinsic muscles of the tongue.
Which ones?
So the genioglossus, the styloglossus, the hyoglossus, and the palatoglossus. These are the 4 extrinsic muscles I'll be checking for.
Okay. Does it always mean when there's restriction in tongue movement that it's invaded by tumor?
Not all, sir. I didn't get a question, sir.
When you have restriction of tongue movement, is it always because of invasion or can it be any other reason?
So a partial restriction of tongue movement can also be because of extreme pain and also the floor mouth involvement, sir.
Correct. Good.
Kinshuk, have you mentioned about dentition? Did you check the dentition on examination?
Yes, sir.
Why is that important?
Sir, I'll check for whether there is nicotine stain teeth or not, whether there is any loose teeth or not. Because a loose during my examination, finding of a loose teeth might indicate that the lesion has crept onto the lingual aspect of the mandible and is basically causing a mandibular erosion as well.
Yeah. Any other reason? Any other thing that you would look for in dentition, especially in
I'll look for. I'll look for if there is any sharp or jagged tooth, because that could lead to a traumatic ulcer, and which if that is left untreated might cause a mucosal change and a carcinoma in future. Yeah, good.
And you mentioned bands on the buccal mucosa. Why did you ask for that on examination?
So this patient has a history of tobacco chewing for quite 25 years. So I like to elicit if there is any OSMF, which might lead to a restricted mouth opening. And with a patient with a restricted mouth opening, during my surgical planning, it will be helpful to know whether the patient has a OSMF or not. Yeah. And it's
so do you look for submucous fibrosis only in the buccal mucosa, or what is the most common site of SMS?
So the most common site is the soft palate and the anterior pillar, sir.
Yeah, so your SMF doesn't mean that it's only there in the buccal mucosa.
Yes, sir.
You've got to obviously examine the pillars and the palate also.
Yes, sir.
And what about caries? Does he have any caries in the oral cavity?
No, sir.
So none of his teeth need to be extracted during surgery?
No, sir.
Oh, okay.
What's the incidence of a second primary, a synchronous primary in oral cancer?
Sir, approximately 3 to 16%, sir.
Good.
So how would you like to stage this, Kinshuk?
Sir, so my provisional diagnosis will be a malignant neoplasm of the right lateral border of tongue, clinically T3 N0 M0. This is based only on clinical findings. However, I like to confirm my findings with radiology and then come to then we'll like to give a clinical radiological staging, sir.
Why do you say it as T3?
Sir, although for clinical radiological staging, I need to know the depth of invasion, which cannot be commented upon without seeing a radiology. But since this lesion is quite thick and it is going, and the invasion is reaching up to midline, I can in the hindsight I can say the depth of invasion will be at least more than 10 millimeter.
So if the dimensions are more than 4 centimeter and the depth is more than 1 centimeter, what would be the stage?
It will be T4A, sir. according to the recent HACC classification.
Yeah. So you can't really say it is T3 or T4A because your dimensions are, I think, 4.5 centimeter.
It's 4 into 2.5.
Okay, fine.
Kinshuk, now that HACC has put up depth of invasion, can we see it clinically?
So for early lesions,
in your case?
no, for this case, not, sir. But for early lesions, if the lesion is pinchable, I can still gauge the depth of invasion. But for lesions which are infiltrative and
advanced cases,
painful lesions, the depth of invasion, and the lesion is not pinchable by 2 fingers, so depth of invasion cannot be gauged. For that, we will require
particularly the patient is having restricted mouth opening.
Yes,
maybe
sir.
not in this case, but in such cases we cannot.
Yes, sir.
How would you like to proceed?
Sir, I like to get a imaging done, cross-sectional imaging. I like to do a distant metastatic workup. I like to do a biopsy in the form of a knife biopsy under local anesthesia, and all the routine investigations before proceeding on to managing this patient. So
what is the incidence of distant metastasis in oral cavity, specifically tongue?
Sir, around 5 to 10%, sir.
Which has got, from head and neck point of view, the hypopharynx has got the highest potential, right?
Yes, sir. Yes, sir.
Yep, go ahead.
So, sir, for investigations, I like to do a knife biopsy in the local anesthesia, a cross-sectional imaging, which in this case will be in the form of a contrast-enhanced MRI. A distant metastatic workup, I like to do a CT scan thorax and routine blood investigation, sir.
Will you do a PET?
No, sir, because the most common site of metastasis from an advanced oral cavity is lungs. And the chances of extrapulmonary metastasis without a lung metastasis is very low, in the range of less than 3%. So for this case, CT thorax will be sufficient, I feel, sir.
Okay, agreed. But in which case will you do a PET? What findings in an advanced oral cancer will make you want to do a PET scan?
Sir, multiple lymph node, multiple neck lymph node metastasis involving multiple levels, bilateral nodal disease, and neck nodes in the lower stations like level 3, level 4.
Yeah, or if the patient has symptoms, right? Symptoms
suggestive of distant mets.
Correct. So PET is useful only to, I guess, stage multiple sites of distant metastasis simultaneously, but not used routinely. Good.
Yes, sir.
Is there any role of examination or anesthesia in your workup?
Yes, sir. Because this is because for this patient, because of pain and the posterior extent of the lesion, I couldn't properly palpate the posterior extent of the lesion. So I need to take the patient up for examination and anesthesia to properly map my lesion, sir. Mainly the posterior extent.
Yeah, because your extent of the lesion, what you said was to the base of tongue.
Yes, sir.
So probably it will be adding your to plan the disease, to plan and what extent resection to be done. So yes, probably you can add up the EUA, or yes, maybe you can do it directly on table EUA during the surgery itself.
Yes, sir.
So how do you want to?
How do you examine the hyoid bone?
So the examination of the hyoid bone has to be done under examination and anesthesia. I like to palpate the base tongue first on both the sides, starting from the unaffected side, and then move my finger down to feel the vallicula, and then by doing a bidigital palpation, I'll put one finger over just above the hyoid from the skin side, and one finger inside the vallicula, and try to palpate my both fingers. So if the pulp of the both fingers meet, I'll say the hyoid is free. If only the tip touches, the margins at hyoid might be difficult, sir. But I'll always like to reconfirm this on my scans.
So in your scan for hyoid involvement, what are the other things that you see? What is the muscle that is relevant for hyoid examination? And is there anything else that you'd like to see?
So I like to see involvement of the geniohyoid muscle on scans in a sagittal section. So if
isn't it the hyoglossus that you see?
Yes, so the origin of the hyoglossus I also like to see, sir, on a coronal section.
What do the roots have spread to the hyoid?
So hyoglossus is better seen on sagittal. Your hyoid involvement also is better seen on sagittal. But anyway, we'll discuss the imaging once you come there. Yeah, good.
So the imaging of the patient was done in the form of a CE-MRI of the face and the neck. The imaging was not done at our center. So the quality of the films was not very good. So this is an actual T1 weighted image. So it shows an enhanced lesion on the right lateral border of the tongue. The enhanced lesion on the left side is because of the dental capping. The coronal section also shows a lesion, enhanced lesion on the right side of the tongue, which is just abutting the mylohyoid sling. And so the base tongue appears to be free over here. The genioglossus muscle is involved, and there is also involvement of the geniohyoid muscle at its origin. It's a 4.3 into 2 into 2.4 centimeter lesion in the right lateral border, T1 hypointense, T2 hypointense with post-contrast enhancement. The extrinsic muscles are involved. The midline is not breached. It abuts the right sublingual gland. The mylohyoid is reported to be free. There's lingual neurovascular bundle involvement focally on the right side. The base tongue is free. There's no cortical erosion of the mandible, and there's no significant cervical lymphadenopathy.
So just one point here, if you know that your patient has had significant dental work done, caps, bridges, and things like that, CT may not be a bad choice. We know that MRI is better for soft tissue for tongue. Yes, but if that artifact is sitting right over your tumor, you're not going to get any information. So that can be a clinical judgment you make when you're seeing the patient and sending them for a scan.
Yes, sir.
In good centers, they have metal reduction CT protocols now.
Correct.
But probably in this patient, you can always argue for a combination of CT and MR if the patient can afford it.
Okay, sir.
So what is the implication? What you told us that mylohyoid is free in the coronal imaging. Does it have any implication, Kinshuk?
Yes, sir. So when the disease on a coronal scan, I like to see the craniocoronal extent of the disease. So first, I like to see whether the sublingual gland is involved or not. So if the sublingual gland is involved, then while resecting the tumor, I'll have to take the mylohyoid in my three-dimensional margin. So if the mylohyoid is in,
yeah, tell me.
So if the mylohyoid sling is also involved, I'll like to remove the mylohyoid, and I like to clear the soft tissues up till the hyoid, sir. So it will be sort of a compartmental resection in that case.
Okay. So when do you want to remove the mandible in tongue cases?
So if the lesion abuts, if the lesion involves the mucosa on the lingual plate of the mandible, or the lesion is very close to the mandible, and I do not palpate a supple mucosa more than 5 millimeter from the lateral edge of the lesion, these are the indications where the mandible needs to be removed. Also, I like to see enhancement, or whether there is enhancement creeping along the medial pterygoid muscles. In that case, also the mandible needs to be removed, sir.
So
and
posterolaterally,
yes, sir.
Posterolaterally, if the tonsil,
posterolaterally,
get a margin there.
Yes, sir. Posterolaterally, if my TLS is only involved, but the tonsils are free, and there is no enhancement in the medial pterygoid muscle, I'll still can preserve the mandible. But if there is involvement of the anterior tonsillar pillars, the tonsil and the medial pterygoid muscle enhancement, I like to take the mandible en bloc with the specimen, sir.
And also in the sagittal cuts, you need to look for the genioid tubercles.
Yes, sir.
Is the enhancement along the junior tubercle a normal finding or an abnormal finding? In the sagittal.
So it's an abnormal finding. Sir.
Right.
No, in many cases, you will see enhancement of the periosteum just outside the cortex of the bone. So unless you have a contiguous tumor from the undersurface of the tongue going all the way to the mandible, you don't consider that significant. Otherwise, in this patient, if you consider the enhancement, then he has to take a part of the anterior mandible. Yeah.
Yes, sir.
So it's not an abnormal finding. In many cases, you will see enhancement along the anterior mandible where the genioglossus is attached. So I think you have to combine clinical and radiology. MRI tends to overestimate a lot of things. So you've got to be very careful when making a choice of resection.
Okay, sir.
Is medial pterygoid involvement common in tongue tumors?
No.
So for advanced tongue tumors, which is extending posterolaterally to involve the tonsillolingual sulcus and the tonsils, there might be involvement of the medial pterygoid muscles as well.
Could be, but I would put that quite low down on the indications for doing a mandibulectomy.
Okay, sir.
Kinshuk, what do you mean by the lingual neurovascular bundle and what are the implications of its involvement?
So the lingual neurovascular bundle is basically the lingual nerve and the lingual vein, which is located just lateral to the hyoglossus insertion at the tongue.
Sorry.
So the involvement of the lingual neurovascular bundle can be classified into 4 types, type 1 to type 4. And the implication of a lingual neurovascular bundle involvement is perineural spread along the neurovascular structures, and this will lead to the perineural spread along hypoglossal nerve as well, and the resection will be and the resection in these cases will be better a compartmental resection.
Yeah, so you would say that by compartmental excision and surgery, you're going to cure perineural invasion by resecting. What is the characteristic feature of perineural invasion in head and neck?
I'm not sure.
So perineural invasion is not contiguous. You can have skipped perineural invasion. So, and the tongue is richly innervated. It's not only the lingual, it's also the hypoglossal. So any tongue tumor, which is this bigger size, will have perineural on final pathology. But that doesn't change your surgical resection unless you find foramina widening or Gasserian ganglion enhancement where the patient is technically incurable. Most of these cases, because of proximity and the rich innervation of the tongue, they will be involved.
Okay, sir.
You said that the lingual neurovascular bundle is involved here. How do you chase it?
I like to see the enhancement along the neurovascular bundle on a coronal section.
Okay.
And
Okay.
this enhancement will be seen just lateral to the insertion of the hyoglossus onto the tongue.
Okay. So what are the signs of perineural invasion on MRI?
So enhancement along the neurovascular bundle and fuzzy planes with the surrounding structures.
What else?
No, how do you see the nerve? You can't see the nerve. You can't see the lingual nerve just like that on MRI, can you?
No, sir.
So how do you know that the proximal lingual nerve is involved?
Not sure, sir.
You look for enhancement of V3 between the pterygoids. And you look at the foramina widening loss of the fat around the foramina, and then muscle wasting by denervation. If it's long-standing, there's muscle denervation. Acute, there is muscle edema. Long-standing, there is muscle denervation. Yeah,
Okay,
but it
sir.
doesn't change our practice because in tongue, every patient who's got a large tongue tumor will have perennial invasion. It's almost, pathologically, it's almost always there.
Okay, sir.
So what's the argument
And as
again?
Narayana said, doing a lateral segmental mandibulectomy for a tongue tumor, unless the tumor is involving the mandible or deep infiltration into the tonsil, or you see obvious spread along the pterygoids, you wouldn't do it.
Yes, sir.
Because there's no data to say that if you remove the mandible in a tongue tumor, you're going to improve outcomes.
Yes, sir.
Yeah, good.
So what are the arguments against a compartment resection? We might be straying a little bit. So we all know about Calabresi's paper. We know about the unusually high local control rates.
Yes.
But what was some of the arguments? What is some of the newer data that's come out that contests that data? Have you read any follow-up papers from Italy? No?
No, sir.
Okay. So basically the issue is that in Calabresi's original work, they may have been over-treating both in terms of surgery along with adjuvant therapy. So that may have also been contributing to the high local and local-regional control rates rather than just surgery itself. Because if you look at the pattern in which these patients fail, right? Many of them don't fail locally and loco-regional. They have a lot of distant metastasis. So the argument is if you are going to demolish their quality of life by doing very morbid resections and the patient comes back with lung mets anyways, what are you really achieving? So it's easy for us as surgeons to say, okay, that looks a little funny on MRI, let's take everything out. But if it's not actually going to contribute to survival, we have to be thinking very carefully, should we be removing it? Because all of this is very morbid. You start resecting the oropharynx, huge margins in the oropharynx, it's going to be very morbid. Patient's not going to swallow. Similarly, you remove large parts of the mandible. Finally, it's just a margin. The mandible is not even involved. But you do a near total glossectomy, big segmental mandibulectomy, and you've taken the entire mandible as a margin. That's not good at all. It's not really going to help anything.
Yes,
So I think that thought process is changing a little bit, where we, like Deepak sir said, you have to be very careful. Clinical assessment is very, very important because on an MRI, many things light up. You have to be very careful. If something looks funny on an MRI, you go back on the patient, you see, you palpate the tumor, you make sure it's not overestimation. Because if you go only by the MRI, you'll end up having 2 centimeter margins. And rather than patting yourself on the back, the patient will be a cripple, both in terms of swallowing and speech. So that's something, in tongue, we have to be very, very careful about. Buccal, it's different. It's lateralized. The functional morbidity is less. Even if you do a big compartment resection, patients still swallow and speak. But tongue, we need to be a little careful about that. So we need to be very clear on what the data shows. Is there evidence that more surgery is beneficial? That's something that we have to be very, very sensitive about.
Yes, sir.
What is the other sequence of MRI that you'd like to use? In fact, I don't look at the T1 contrast as the first image. I always look at something else. What is a better sequence which takes into account the tumor contour, tumor edema, and all of those things?
So the stir sequence, sir.
Correct. So the stir sequence is probably better for anatomical contour of the tumor because it doesn't overestimate as the contrast image does. Very good. So how do you manage this patient? You've done the imaging, you've done the distant metastatic workup.
Yes, sir. So the biopsies are.
How would you answer this question in the exam? If they ask you how do you manage this, treat this patient, what would be your answer in the exam?
I like to treat this patient surgically. And
First, what comes
So
before
you like
that?
to give curative intent treatment or
it's a curative intent treatment.
palliative intent
It's a
treatment?
curative intent treatment, sir.
So you start by saying you'd like to offer curative intent treatment in the form of?
In the form of a surgical resection of the tumor,
Which includes?
which includes a wide excision glossectomy with adequate margins and a neck dissection and a reconstruction thereafter.
Followed by?
Adjuvant treatment, depending on the final histopath report, which might be only adjuvant RT or adjuvant RT with concomitant chemotherapies.
Yeah, so that's how you answer in the exam. You want to give a curative intent treatment in the form of surgery, which includes a wide local excision, neck dissection, and post-op adjuvant treatment as indicated by the histopathology that you get. This is the answer. So I have a very basic question for you. What is the adequate margin and whose data do we follow for that adequate margin?
So the adequate margin will be 5 millimeter, at least 5 millimeter for to call it a clear margin.
Gross microscopic?
You have to say gross and pathologically. So that's
gross margin should be aimed at 1 centimeter, and the microscopic will be 5 millimeter.
okay. So whose data is that has that come from?
So this was initially given by
Very
the
simple question.
So this was initially given by the cutoff of 5 millimeter microscopically as clear margin was initially given by the American College of Pathologists, and later there has been work from Zanoni.
No, whose data did it come from? American College of Pathology gave a paper, that's all. But whose data did it come from? It's such a common thing. No, you keep saying 5 millimeter margin is adequate. I say 1 millimeter pathological, 1 centimeter pathological is adequate because there are a lot of papers which say that the greater the pathological margin, the greater is the local control rate. And there are papers which say against that. So who gave the data that 5 millimeter pathology margin is adequate? Simple question. No, very simple question.
Sorry, sir, I don't remember. Sir.
I'm talking about oral cavity. We're not talking about other sites. I'm talking about tongue and buccal mucosa. So that's your lesson for today. You have to go find that out. Okay, so you're going to do all these. What is going to be your approach in this patient? What is your surgical approach in this patient?
My surgical approach will be a visor incision with a pull-through approach, because my even with a full mouth opening, I'm not going to get the posterior margin without a pull-through.
But if you do a pull-through, you're going to take the whole floor of mouth and de-innervate the entire floor of mouth. You said that you can, it's a lateralized tumor, no?
Yes,
if you do a pull-through, you're going to take the whole tongue into the neck. So do you want to de-innervate the rest of the floor of mouth, or you understand my point? You're going to pull the whole tongue down into the neck.
Yes, sir.
And then you've got to resuture the floor of mouth back to the gingiva.
Yes, sir.
Is it for a lateralized tumor, which is infiltrative? Is there any other approach that you can think of?
I can also think of doing a mandibulotomy approach to access the tongue, sir.
So which do you do when? How do you decide?
So between pull-through and mandibulotomy, is there any difference in oncological outcomes?
No, sir. There's no difference in oncological
There was
outcomes.
a systematic review published on that. Okay, so what are the advantages of a pull-through? What are the advantages of a mandibulotomy?
Other than visor, can we do in other way, Kinchu? Pull-through can be done in other way, right? When you give a midline incision up to the chin, still
yes,
you can
sir.
have an access for the pull-through.
Yes, sir.
where you won't be disturbing the other side of the tongue.
Yes, sir.
And keep the floor of the mouth muscles of the opposite side
Opposite
intact.
side intact. Yes, sir.
So what is the implication of the floor of mouth muscles? In the post-operative,
Yes, sir. So
will it help in initiating the swallowing early, right?
yes, sir.
So think about it simply. What gives you best access to the entire tumor? Number one. Number two, what is least morbid? What is disrupting function?
Between mandibulotomy approach and a pull-through approach, the least morbid will be the pull-through approach, because the mandibulotomy approach will involve cutting the mandible and again repositioning it with mini plates and screws. And
No, I don't think that's the right answer. Mandibulotomy, if done well, is still a good mandibulotomy.
Correct.
A pull-through is actually very much more morbid than a mandibulotomy. Yeah, and then lip splitting for a tongue tumor is, I don't think, is acceptable, because you don't want to denervate the lip. Already his tongue is gone. You don't want to denervate his lip and make him orally incompetent, because once you elevate the lip from the mandible, all the muscles will go. So your answer should be, mandibulotomy versus a pull-through. Both are acceptable. I don't think one is better over the other. I do agree that in the mandibulotomy, you have to put hardware there and you have to fix the mandible again. But in a well-done center, it's a good option. It's just because you don't do mandibulotomy for tongue doesn't make it a bad surgery. Yeah.
okay, sir.
Correct. I think mandibulotomy makes perfect sense. If you're not disrupting the entire floor of the mouth mylohyoid, and you're worried about the posterior margin, if you're thinking about the oropharynx based tongue tonsil, mandibulotomy gives you very good access to all of that, and you're not disrupting lip function, you're not disrupting swallowing, you're not unnecessarily resecting the floor of mouth.
Okay, let's say you've resected the tongue. It's a near total glossectomy. You've resected the floor of mouth also based on your scans. The contralateral tongue is intact. How do you like to reconstruct this patient? We'll go to the neck dissection later.
Yes, sir. So the main aim of reconstruction after a major glossectomy will be to provide a pliable soft tissue and help in swallowing and speech. So with in this particular case, with a major glossectomy, which will entail a near total glossectomy, I like to reconstruct with a free flap, which will be in this case mostly a free anterolateral thigh flap, sir.
Okay, so how do you decide the flap? If the patient is very thin, ALT won't have any bulk or anything like that. So how do you decide?
So there's an article by Manelli et al. Which has classified glossectomies into 5 types, and for each type of glossectomy, they have proposed the adequate reconstructions which can be done. So for a lesion, so according to that classification, this glossectomy will be a type 4A glossectomy, and for type 4A glossectomies, my main aim will be to provide a bulk which will require a good soft tissue. So if the patient is too thin and the ALT is not going to provide that bulk, I like to consider for a PMMC as well. Otherwise, ALT will be more preferable than PMMC in terms of long-term swallowing and speech.
How do you tunnel a PMMC with an intact mandible?
So when we are doing a pull-through approach after excision, the floor of the mouth is opened on that particular side. So the PMMC is harvested. I'll first like to take the posterior sutures at the RMT. Once that is being done, I like to do the posterior suturing with the intact base tongue of the opposite side, and then interdented stitches along the mandible coming from posterior to anterior, unless the normal sided tongue is met, where the sutures will be with the normal residual tongue.
So where do you get that much fat in the PMM? And what intercostal space tissue you have to include in your PMM? Usually it's the paramammary tissue,
Yes,
which
sir.
is rich in perforators. They will support the skin pattern. And this is a male patient, so there's no distortion of the breast. And you also make sure that your skin pattern is over the fifth intercostal space, because that's where the most dense perforators are. Yeah.
Yes, sir.
So you told me two choices, ALT and pec major. So, and what is the vascular supply of the pec major?
Sir, ALT.
ALT will be a theory question. If I set the paper for you, it will be a theory question.
Basic flaps you
Okay, what's the vascular supply of the pec major?
Don't be nervous, Kinshuk.
Yes,
Go
sir.
in and out, right?
I think I'm your examiner this year, so you better be prepared.
Sorry, sir. Sir, it will be the pectoral branch of the thoracoacromial artery, sir.
Yes.
Yep.
Pectoral branch of
Excellent. What's the
pectoral
other blood supply?
So the lateral thoracic artery will also, a branch from the lateral thoracic artery will also be a blood supply, sir.
Yep.
Yeah, good. So thoracoacromial artery gives pectoral branches, and that's what you do. So if you want to preserve the bulk of the pec major, you know that post-radiation, all these flaps will shrink in some time. You know, that's the biggest problem
Yes, sir.
with these flaps, correct? Post-radiation, they become a flat diaphragm in the oral cavity. You won't see any bulk left. So what are the special things that you will do that you won't do in any other case with the pec major?
Think about it. What do you routinely do while raising the pec major?
So while routinely we, for this patient, I will not like to clip and divide the lateral thoracic nerve, sir.
There's no lateral thoracic nerve. There's a medial and a lateral branch from the plexus. So one runs through the pec minor and then comes to the pec major. That is the medial branch. And there's one which runs along with the pedicle. That's a lateral branch. It changes position. Medial is lateral, lateral is medial. So normal circumstances, you want for a buccal mucosa, you would want it to shrink. So you divide the nerves.
Yes, sir.
But in tongue, you want to preserve the bulk. So you preserve the nerves. But the problem is each time the patient moves his arm, it's going to pull on the flap. That is something that you have to remember.
Yes, sir.
What can you do if the patient has a thin leg to improve the quality of the ALT if you want bulk? Anything you can do differently in the ALT if you want more bulk for a tongue reconstruction? Can you harvest muscle? What muscle? It's okay. Read ALT.
Yes, sir. Yes, sir.
One thing is preserving the innervation of the muscle, either with the pec major or with the vastus. How else will you make the tongue protuberant? If you have a lot of suprahyoid dead space and if the floor of mouth has been harvested, what can you do?
What do you routinely do at the end of the surgery, Kinshuk, like in the tongue cases?
Yes, sir.
Where when you do a total glossectomy or subtotal,
Yes,
at
sir.
the end of the procedure, what you usually follow, you try to take one stitch, right?
Yes, sir.
Why do you want to do this?
No, sir. Sorry, sir. I am not getting the question actually, sir.
No, at the end of the procedure, like always we try to do in the total glossectomies, one stitch like hyomandibular suspension.
Yes, sir.
So why do you want to do that?
So that is because when we do a total glossectomy or subtotal glossectomy, we cut the muscles, the suprahyoid muscles. So so this hyomandibular stitch will, so when we cut the suprahyoid muscles, this is during swallowing, the hyoid is not elevated. So we like to take the.
No, what does the stitch do? What does it do to the epiglottis?
What does it prevent?
It prevents aspiration by.
Yes,
it will help during swallowing. It will help the epiglottis to fall and cover the laryngeal inlet, sir.
Correct. As long as the patient
So
has
what is the other surgery that you can do to make the laryngeal inlet narrower? So you can do an epiglotoplasty also,
Okay.
whereby you pull the epiglottis downwards towards the arytenoid and stitch them together, narrowing the laryngeal introitus. But what I wanted to ask you to keep it protuberant is that you have to recreate the floor of mouth also. So you recreate the oral diaphragm by stitching the muscle between mandible to mandible. Okay, so enough of reconstruction. What neck dissection will you do for this patient?
So, sir, it's an advanced, it's a tongue carcinoma with advanced T stage. The neck is, however, N0, both clinically and radiologically. I like to do a comprehensive neck dissection in the form of a modified radical neck dissections, levels 1 to 5, preserving all the 3 non-lymphatic structures.
But you said it's N0.
N0 on imaging, you want to do an MRND?
Sir, it's a advanced tongues. It's mostly a T4 tongue, sir. I like to address level 5, sir, as well.
What's your evidence for that?
Sorry, sir. The recent evidence says the incidence of in an N0 neck, the incidence of level 5 metastasis is around 3.8%. And sorry, sir. I rephrase my answer. I like to do a selective neck resection, and I like to send level 2A for frozen. If the level 2A comes positive on frozen, I like to address level 2B and level 5, sir.
What was the evidence for skip metastasis? Who are the 2 papers? It started with Jatin Shah's R&D paper. Then it went on to somebody else from MD Anderson, and then somebody else also. So what are the 2 papers which contradicted each other for skip metastasis?
So the concept of skip metastasis was first given in the bias paper, sir, in which they have said, particularly for tongue lateral border lesions, there is a chance of metastasis to level 4 without causing a nodal metastasis to the first echelon, which is level 2. So this has been contradicted by many other articles, and one is from
no, which person specifically? It came in Head and Neck, the journal Head and Neck. Dyers, have you read Dyers' paper? So Byers and Dyers contradicted each other. So I wouldn't do a level 5 neck dissection for this patient unless there was level 4 positivity or low 2B positivity. I wouldn't do it. So what is spinal accessory syndrome? I didn't ask you spinal accessory dysfunction. I asked you spinal accessory syndrome.
Yes, sir.
Who described that syndrome? Okay, what are the consequences of long-term spinal accessory nerve palsy?
So there will be wasting of muscles over the shoulder, and inability to abduct, or inability for overhead abduction of the arm, sir.
That will be there if you have acute spinal accessory nerve palsy also. I'm asking you, what is the long-term problems of spinal accessory nerve syndrome?
What happens to the shoulder girdles, scapula? What happens?
If you don't use your arm to move anything because of spinal accessory nerve syndrome, what happens to the joint and all the muscles of the rotator cuff and the shoulder girdle?
So there will be
the capsule of the shoulder joint itself.
There will be diffuse atrophy of the muscles of the shoulder girdle, sir.
What will happen because of that?
Specifically, what happens to the capsule is asking.
It will lead to adhesive capsulitis, sir. And there will be inability.
Excellent. That's a good answer. And
Correct.
then patients also have pain. Why? So what happens is there's a traction on the brachial plexus.
Okay,
because the patient can't abduct the arm, and the weight of the arm is borne by the entire shoulder joint and the neural connections above that. They have stretching of the brachial plexus. So they have a lot of pain. So what prosthesis can you use for such patients? Is there any specific prosthesis for long-term spinal accessory nerve dysfunction, where you can support the arm and the shoulder and all? What's the name of that?
Not heard of, sir. Sorry, sir.
So there's an excellent article in eMedicine on spinal accessory nerve dysfunction. So it's Medscape, it's free. Please go through that article. Yes. And they've given how the supraclavicular nerves, because you divide the supraclavicular nerves during an MRND or an RND, that causes pain and paresthesia along the entire infraclavicular area, and that also mimics. So there are some mimics to spinal accessory nerve dysfunction. You necessarily might not have divided the spinal accessory, but you would have divided the 3 supraclavicular nerves that come over the clavicle, and that leads to pain and paresthesia, and they don't move their shoulder, and then that has the same sequelae. So spinal accessory nerve syndrome is an exam question.
Okay, sir.
If you send me your email ID, I'll send you, because there's a trial that I'm doing with that, so I can send you the material for how you assess spinal accessory nerve dysfunction, what is EMG in spinal accessory nerve dysfunction, and how you assess that. Okay.
Okay, sir.
Then what else? Okay, so you have cut the marginal mandibular nerve during your neck dissection. What do you think are the sequelae for that? And what is the neural hammock of the marginal mandibular nerve?
What muscle does it supply? Go systematically.
So it supplies the orbicularis oris, sir.
Which part?
No. No.
What is
Orbicularis oris is a combination of muscles. What specific muscle does it supply?
It supplies the depressor anguli oris, sir.
Yep.
Correct. So what will happen if you denervate that nerve?
So the depressor anguli oris of that particular side will not work. So when the patient tries to smile or the lip in that side.
No, have you seen a marginal mandibular nerve palsy patient? What happens to that side of the lip? What are the two things that happen to that side of that lip?
So while we ask the patient to smile, that particular side of the lip won't depress as compared to the other side.
Correct. So what happens to that lip? Have you seen a long-term marginal mandibular paralysis patient? How is that lip? Is it bulky? Is it thinned out? Is it wasted?
That is thinned out, sir. That particular side is thinned out.
Is thinned out. So they can't pout, they can't evert the lip, and there is oral incompetence there. Correct?
Yes, sir.
So the patient comes back to you and says, I want correction of this defect. How do you do it? And what is the other thing that can cause the same picture? Let's say you preserve the marginal mandibular nerve, but still the patient has problems with everting the lip and all those things. What is the other muscle that has caused this problem? The platysma. Because the platysma also interdigitates and goes up to the lip. So if you have denervated the platysma also, the patients might have similar complaints to that of the lip. Yeah. So I'll let others talk because I've been asking a lot of questions on reconstruction. The last thing, adjuvant treatment.
Yes, sir. So adjuvant treatment will be guided by the final histopath report. And so this patient is clinically T4AN0. So mostly he will be requiring an adjuvant RT. And depending on the final histopath, I'd like to comment whether he will be requiring an adjuvant CTRT. So the only indications of...
so I know that your chemo RT paper comes from Bernier and Cooper and all that.
Yes, sir.
So who gave the risk stratification for adjuvant RT? You know the indications for adjuvant CTRT.
Yes, sir.
So Bernier did a paper, one was RTOG, one was URTC, then they combined and gave a paper out of that.
Yes, sir. Yes, sir.
But who told you how to give adjuvant RT in the first place? So what did Lester Peters' article tell you? Very old article, and then followed up by Key and Ang. How do they stratify the risk in oral carcinoma? Peters was the first paper, Ang was the second paper. How do they classify what is risk in oral cancers for adjuvant RT? So are you there?
Yes, sir.
I suggest you read Harrison once when you have the time.
Yes,
sir.
Okay, how will you prognosticate this patient and how will you follow them up? Any role for baseline imaging post-treatment?
Sir, the follow-up protocol that is followed in our institute is after completion of adjuvant treatment, I'll first like to see the patient at 3 months, and it will be 3 monthly for the first 2 years, followed by 6 monthly for the next 3 years and yearly thereafter. And I like to get a basic imaging after 3 months, which will serve as a baseline for further for follow-up protocols.
Do you know what the different guidelines are for baseline imaging? What are the British
That's a
guidelines?
very important question.
British one.
That's a very important question.
Because they don't all agree, right? And what's the prognosis of this patient? So after radiotherapy, patient comes back to you, family comes back to you. What is the prognosis? What is the survival at 5 years?
And adding on to that, what are the tools for prognostication? HPR doesn't give prognostication. What are the tools for prognostication?
So one thing is you should know the 5-year survival for these patients.
The 5-year disease-specific survival for a T4 tongue after completion of adjuvant RT will be in the range of around 30 to 35%, sir. This is disease-specific survival, sir.
Whose data is that? T4N0, 35%?
This was...
He asked you not DFS, he asked you OS. There's a lot of difference between the two.
So what Deepak was asking was nomograms. Do you know any way to personalize that prognostication? Any nomograms you've heard of, any you read about in oral cancer? Because the stages are very broad, right? Stage 1, 2, 3, 4. Stage 4 can be T4N0, it can be T2N2C, it can be T4N3B, right? So we have a lot of difficulty trying to prognosticate patients. So any nomograms you know of? Okay, and how will you rehabilitate?
Any histopathological thing do you know of? Brandwein, Gensler, or AFP prognostication? Do you know any of those things?
Yes, sir. Sir, the worst pattern of invasion.
No, just tell me what Brandwein, Gensler, the subgroups are and how it was useful to prognosticate. Like Narayana said, one is nomograms, that's coming up in a big way. And it's very popular for other sites. We are trying to develop it for head neck. So is there any other technique? Is there any other hematological technique that you know of? What are the hematological markers? What are the ratios that people have looked at for prognosticating?
There's some papers from TMH also, no?
Neutrophil lymphocyte ratio, platelet this ratio, that ratio. I'm not giving you the entire answer, but do you know of any hematological ways to prognosticate your patient? It's cheap, it's simple. You have baseline data as pre-op data from your investigations. Do you know of any hematological systems that are available? And like Narayana said, there's a paper from Tata also.
My last question, what are your rehabilitation goals for this patient? So you discharged him maybe with a tracheostomy and Ryle's tube/peg at 10 days. He's okay, everything's fine. What are your rehabilitation goals?
So I like to start an oral feeding for this patient as early as possible. So the average time for removal of trach tube is around 7 to 8 days, and for NGT is around 10 days. And I like to avail the services of the speech swallow therapists and see whether the patient is aspirating while taking liquids. And if he is not, then I like to start off with liquid diet on day 10 and semi-solid and soft diet thereafter, sir.
How do you assess that aspiration?
So, so this is by penetration aspiration score, sir. So, so I like to do at bedside. I can do a modified water solo test.
Okay.
By giving 100 ml of water to drink and see the whether there's elevation of the larynx or not, and whether the patient is coughing immediately after taking the water. And objectively, I can do a feast to see whether the patient is aspirating or not.
So bedside water test, how will you know if the patient's aspirating?
This bedside water test was never meant for head and neck. It was meant for stroke patients, actually. So our patients, there's a bedside aspiration is one, silent aspiration is the other, different consistencies another problem. So basically, how would you assess patient being fit to be taken off the tubes?
So what do you want to remove first, whether it is a tracheostomy tube or a feeding tube?
The tracheostomy tube first, sir.
What was the indication? Like, why do you want to do the tracheostomy in these cases?
So it's a as a prophylactic measure for protecting the airway, and also since one side of the base of the tongue was removed as part of the resection, there will be chances of aspirating the saliva. So I like to protect the airway, and that is the reason for doing a tracheostomy for these patients.
So you just remove it, or would you do a trial block for some time?
I'll try to first I like to deflate the cuff of the tracheostomy tube and see whether the patient is aspirating the saliva or not, whether he's coughing more vigorously than before. If not, I like to change it to an uncuffed tube.
But aspirating saliva will not manifest immediately. It will end up in pneumonia and your patient will die.
It will be silent, right?
So how do you
It's not going to use a double or a single lumen?
We generally use a single lumen cuff tube at the time of surgery, and then try to change it, then change it to an uncuffed tube and cork it.
So the moment you uncuff your tube, he's going to aspirate because all the pooled saliva will be above the cuff. The moment you release the cuff, everything will go into the lungs.
So you'll teach him some maneuvers, right?
Yes, very
yes,
important point.
Any idea about the maneuvers, what you wanted to teach in a total glossectomy patient?
Very important. Very, very important. No, there are supraglottic, supraglottic, Mendelssohn. There's so many maneuvers. What would you treat? What will you teach?
So can you rate this aspect? Like, what are the rehabilitation aspects?
Yes, sir.
And what are the maneuvers that you try? Like in this patient, the patient will be losing what sort of the swallowing phase? Pharyngeal?
Yes, sir.
So oral phase, right?
Yes, sir.
So when each of it is lost, so what are the maneuvers which we will try to teach the patients in the post-operative period? Okay.
Okay, sir.
You have to know this. These surgeries we do are very morbid. So unless we personally take interest in rehabilitation,
so not only the surgery, the quality of life is the most important thing which we need to see, especially in the total glossectomy or subtotal glossectomy patients. So the early rehabilitation is the key.
Yes.
If the patient is not swallowing and decannulated before radiotherapy, their recovery is very, very slow.
Now, before radiation, if you're not able to remove the tubes, then it is very difficult for the patient to come out of the tubes. So most of the times they become tube dependent. So post-surgery, our main motto should be as early as possible. We have to rehabilitate the patient, make him swallow, remove the tubes as early as possible, so that the quality of life has to be maintained. This is the most important aspect of any total glossectomy patient.
Okay, sir.
Otherwise, even closing the tracheostomy becomes difficult. The tracheostomy will be in the radiation field. Even closing it becomes difficult. You keep suturing it, it will keep popping open.
Should we take any questions in the chat box?
So in the long term, what is better, nasogastric or PEG? What's the evidence for and against? And do you know of any review that has been done on this subject?
No, I haven't read of, sir.
So what is the advantage of nasogastric tube? And what is the advantage of PEG?
Simple. Think logically.
And what is the paper from North America stating about prophylactic swallowing exercises? It may not be in this context, but for oropharynx and supraglottis, what would you, how would you counsel the patient pre-op about their swallowing status? Because you got to tell them that it will be quite some time till the oral phase is rehabilitated. You'll have chewing, but you won't have propulsion, because the tongue might not touch the palate. So you might not have propulsion. There might be false feeds or superseded feeds where there might be some residue left in the oral cavity after the initial swallow, and this residue will drip down into the larynx, because even radiation, if you have mucositis, patient will not have any supraglottic sensations whatsoever, and he will continue to aspirate. So the primary question is like how, whether you remove the Rein's tube first or the tracheostomy first, considering that this patient is going to receive full blast radiation.
So you're there, Kinchu?
Yes, sir.
So all these aspects you need to read for the exam, Kinchu,
Yes, sir.
especially the rehabilitation and
Okay, sir.
other than that reconstruction part. Okay.
Okay, sir.
Good. It was a nice presentation.
Good job.
Well done. I think it's 7:20. I think we are beyond our time. So will the convener come and give some closing remarks?
Yes, sir. Thank you so much for your time for this, taking out your time for this class. It is very important to understand the importance of rehabilitation while dealing with head and neck and oral malignancies. Not only for the exam purpose, but also in our routine clinical practice. And until unless we take a very keen interest in it, it is very difficult to get into the real rehabilitation practice. So a very well taken point from the discussion today. Sir, I would like to invite you for some closing remarks on the presentation presentation by Dr. Kinshuk, all three of you, Dr. Deepak, Dr. Narayan, and Dr. Kranti, before we proceed to close the session.
I was happy the way he presented. He got his clinical findings correct. He got his radiological findings correct and his treatment correct. There's always something to learn about reconstruction rehabilitation. And just put some effort into that. Speak to your plastic surgeon, speak to your swallowing therapist. Because at the end of the day, when you're practicing, everybody will come on your head. Every little complaint will be given to you. So you've got to realize that. And I hope to see all of you in Tata as an examiner in a couple of months. Thank you so much for this opportunity and very well done. All the best.
One more thing, there's one question in the chat box when we were discussing about mandibulectomy. So the question is that when the disease is present in the paramandibular region, in the soft tissue, do we go ahead with mandibulectomy or not? Anyone? Deepak sir, Dr. Narayan, Dr. Kranti, anyone?
Yes, I think traditionally, if there's paramandibular space invasion, you're supposed to take the mandible. We're not quite sure whether it contributes to improved oncological outcomes. So I guess you have to look, it has to be a decision that, at least for me personally, my opinion, you have to take that decision on a case-by-case basis. You need to see whether that paramandibular space involvement is focal or not. It's a hard question to answer. I think it's still a little doubtful. So I wouldn't be very happy taking a large segment of mandible as a margin, as I mentioned earlier. Probably if it was very close to the mandible, I'd see where it's close to the mandible and try to get away with as little surgery as possible if I was taking the mandible as a margin and not because the tumor was involving the bone.
Great point.
I agree with Narayana because dissecting the tongue and the mandible will make the patient a total cripple because he will have malocclusion. Even the oral phase, whatever little is remaining out of that, the chewing, mastication, everything is a problem. And there's no grading for paramandibular spread as yet. We don't know what is the least and what is the most. So we don't really have any clear idea on that. But if you're doing a glossectomy, I would try my best to preserve the mandible. But if the glossectomy does involve removing the mandible, I would do a bone flap because I don't want to make the patient a total oral cripple where he can't chew. Putting a soft tissue ALT that way is not going to rehabilitate a patient in any way. So I would, if the patient has tongue and mandible taken out, I would put a bone flap there and somehow try to reconstruct the tongue also in the same surgery. But it's a very crippling thing. Doing a total glossectomy and laryngectomy is far less crippling than doing a glossectomy with a mandibulectomy. So I would try to preserve the mandible as much as possible or reconstruct the mandible without any doubts. Never put an ALT for a segmental glossectomy because the patient will never swallow again in his life.
Dr. Kranti, would you like to comment?
As discussed earlier, most of the times the mandible is not involved. The periosteum in the total glossectomy cases, the mandible periosteum per se, if you see it pathologically, most of the times the report will be negative. But still for the paramandibular component, when you see the mylohyoid line, if it is breached through and through, yes, I would definitely considered to do a segmental mandibulectomy in these.
So I think what we understand here is that in cases where there is mylohyoid breach, so that we don't get an adequate margin inferiorly to do a marginal mandibulectomy, we can go ahead with segmental mandibulectomy, but if done in such scenarios, we should definitely reconstruct with a bony flap. I think we're on the same page, all of us.
Yep.
Great. So I think we can end the session now. I would like to thank everybody, especially all our faculty members, Dr. Deepak, Dr. Narayan, and Dr. Kranti, for taking their time out today. And it has been a wonderful session, especially for all the students from TMH Mumbai who have seen Deepak sir before their exams actually. So it was kind of a mock exam for them. Thank you, sir. Thank you for coming.
This is cheating.
I agree, sir. It's absolutely cheating.
Okay, he has enough questions
Thank you
to ask
very
you
much.
that weren't there.
Thank you, sir. Thank you.
Narayana knows.
He has enough questions, don't worry. Agreed, agreed. I have spent some time with Deepak sir. I know he has enough questions in his armamentarium. Thank you everyone for
Thank you
coming.
so much for this opportunity. It was really great.
Thank you.
It was really great. Narayana, Kranti, very good to meet you guys again.
Thanks, sir. Thank you.
Thank you, sir.
Yeah. Take care, all of you.
Sure. Thank you.
Yeah. Thank you.